Good day, everyone. Welcome to another chapter in pathology. I'm Abdullah Asad. I'm a medical student at King Saud bin Abdulaziz University for Health Sciences. And today our talk is going to be about cervical cancer, which is a very important topic in pathology. So without further ado, let's get started. Now here is basically an outline of what we're going to talk about today in our lecture. Now here's a slide about the histology of the cervix. Now we have two parts. We have the endocervix, which you see over here, and we have the exocervix, which you see over here. Now the endocervix, the histology of the endocervix is basically simple columnar, and the exocervix by stratified squamous. Now we have an important part in the histology, which is over here, where the simple columnar turns into stratified squamous. Here, this is what we call the transformational zone, or the T zone. Okay, this is very important because the cervical cancer usually happens in that zone. Now, talking about risk factors, the number one and most important risk factor is HPV, which is human papillomavirus, and they like to ask that on exams. They're going to ask what's the most important risk factor for cervical cancer. The answer is HPV, because 99.7% of cervical cancers cervical cancer patients have HPV infections. And there are other risk factors that support this. For example, sexual relations at young age or having multiple sexual partners. All of that support HPV. Another risk factor is LKB1, which is a gene, and this is usually affected or mutated in many gynecological cancers. Okay, and this is found in approximately 20% of cervical cancers. Okay, another risk factor is smoking, a very important risk factor, and immunosuppression HIV. Immunosuppression in HIV is very important. Why? Because cervical cancer is an AIDS-defining disease. What does that mean? It means if someone who has HIV and then develops cervical cancer, that means we can tell that this person has now entered into the AIDS stage. Okay? That's a very important risk factor. Now, talking about HPV, we have two categories. We have low risk and we have high risk. Now, what are we talking about when you say risk? Well, basically, risk of developing cancer. Now, low risk, we have two kinds, 6 and 11. These usually develop into or give us condyloma, which is basically genital warts. Okay, and if you want to know more about that, you can check out our video about STDs. Now, the other type, which is high risk, we have the 16 and 18, plus we have the 30s, which is 31 and 33. But most importantly, we have 16, 18. These are most important. And what they cause is basically cervical intraepithelial neoplasia, or CIN. And this cervical intraepithelial neoplasia has the risk to become or might become cervical cancer. Now, once we have an infection with HPV, it's based on the type. So if we have infection with type 6 and 11, we're going to get condyloma or genital warts. If we have 16 and 18, we're going to get intraepithelial neoplasia, or what we call CIN. Okay, now how does 16 and 18 cause CIN? Well, basically they secrete two kinds of proteins, which you see here, E6 and E7. E6 and E7, what do they do? Well, basically E6 inhibits or prevents P53, and E7 inhibits the RB gene. Okay, so they deactivate the P53 and the RB gene. Now, once we have intraepithelial neoplasia or CIN, there's two pathways. Either it will regress or spontaneous clearance, or it will develop into invasive cancer. So here is basically a review of what we said. So we have an HPV exposure. Either we have 6 or 11, which is going to give us condylomas or genital warts. What you need to know also about 6 and 11, that it's an episomal infection, or it has an episomal replication. Okay, or we have a high risk HPV, which is 16, 18. And what you need to know about the high risk, it has viral integration. So it's going to integrate its viral genome inside the normal cells. And another thing about HPV, it's a DNA virus. Okay, that's very important to know. And then you'll get cervical intraepithelial neoplasia, which with persistent infection could cause invasive cancer and then metastasis. Now here we have cervical cancer types. We have the squamous cell, which is the most common type. This is very common question in exams. We have adenocarcinoma, and we have small cell neuroendocrine carcinomas. Now, another thing you need to know, that squamous cell much caused by HPV 16 and adenocarcinoma by 18. Okay, so what you really need to know is they're going to ask what's the most common type of cervical cancer, and the answer is squamous cell. Very important. Now in this slide here we're going to explain exactly what is cervical intraepithelial neoplasia. Now once we do a biopsy and check out the tissues, we're going to see what level of CIN we're in. Now we have 3 levels of CIN. Number 1 is when we have 1/3 of the cells are infected. CIN2 is when you have 2/3 of the cells infected. CIN3 if we have almost all of the layers infected. Now, if we have all of the layers infected, we call that carcinoma in situ. Now sometimes CIN3 and carcinoma in situ are a little bit hard to differentiate if we have all the layers or not, or almost all the layers, so we put that sometimes under the same name, which is CIN3. Now, how do we know that we have invasive cancer? Is basically once we see the cells going through the basement membrane, as you can see here, and that's what's going to give us invasive cancer, and it's going to tell us that now the cells have the capability, or this cancer has the capability of metastasizing to other organs. Now, as we said, this diagnosis is done after a biopsy, so this is a histological diagnosis. We have another system called the Bethesda system. Okay, this is after doing a pap smear. So this is a after doing a pap smear, which we're going to talk about later. So this over here is a cytological diagnosis. We have 2 kinds. We have LSIL and HSIL. LSIL standing for low-grade intraepithelial lesion, and HSIL for high-grade intraepithelial lesion. Now LSIL, that means you're at grade CIN1, and HSIL is either CIN2 or CIN3. Now here's when we talk about cervical carcinoma. Okay, so another reminder, that's the most common type is squamous cell. So presentation usually asymptomatic, but you can have presentation as metrorrhagia, vaginal bleeding, especially postcoital, discharge or cervical ulceration. Complication. Now the complications, the most common cause of death with people in cervical carcinoma is basically that the tumor will grow big and big and big until it obstructs the ureters, and then the urine flow will be obstructed, therefore causing hydronephrosis and death. That's the most common cause of death in cervical cancer patients. Now over here is, on the slide over here, you have a pap smear. This is the result of a pap smear. Now what I want to show you is the difference between a normal cell and a cancerous cell. Now, this pink cell over here, this is a normal cell, okay? And what you see here is that we have a small nucleus, but a large cytoplasm, okay? Now, in a cancerous cell, well, what do we have? We have the opposite, basically. We have a large nucleus and small cytoplasm. What you see, the large nucleus is in dark blue and the cytoplasm is in light blue. Okay, now let's talk about screening and diagnosis. Now for screening, we have pap smear. It's the best screening method, not only cervical cancer, but in general. It's one of the best screening methods ever created in medicine. It's the gold standard for screening, okay? What do? We say in pap smear, we scrape the cells from the transformational zone, the T zone. We said that cancer usually happens in this zone. Screening starts at 21 or 3 years after first sexual activity, whichever comes first. You either turn 21 first or 3 years after sexual activity. It's done annually until the age 30, then every 2-3 years if 3 normal. So if you reach the age of 30 and you already have 3 normal results, you can do it every 2 to 3 years. If in the pap smear you find abnormal results, then you have to do colposcopy and biopsy. Now this is very important. You cannot diagnose cervical cancer by only pap smear. You have to do biopsy, okay? Very important. Now this table is showing us the regulations in pap smear. So important things, we just want to go through the important things. Before the age of 21, no screening. It starts at 21. If you reach 30 and you have 3 normal results, you can do it every 3 years, okay? And if the patient has total hysterectomy, there's no need to continue screening. These are the most important notes. So here we have the staging of cervical cancer. Now another thing important to know is that cervical cancer is the only gynecological cancer that is staged clinically. Okay, now we start off with carcinoma in situ at stage 0. Then we have stage 1, which is confined to the cervix, only in the cervix. Now once it starts spreading, if it spreads but doesn't reach the pelvic wall, or the lower 1/3 of the vagina, as you can see here, we call that stage 2. Okay, so as you can see here, 2A, it reached the upper 2/3 of the vagina. Stage 2B reached the parametrium. However, they did not reach the pelvic wall nor the lower 1/3 of the vagina. If that happens, if they reach the pelvic wall or the lower 1/3 of the vagina, you have now reached stage 3. Okay, as you can see here, stage 3A reached the lower 1/3 of the vagina. Stage 3B reached the pelvic wall. After that, we have stage 4, which talks about metastasis. Now, stage 4, you have 4A and 4B also. 4A, if it metastasizes to somewhere nearby, for example, the bladder, and 4B, if it metastasizes to somewhere far away. Okay, now here's a table to summarize what we just said. Now, we have stages 1, which is, we said, is limited to the cervix. Okay, so you have 1A, less than 5 millimeters, 1B, more than 5 millimeters. We have stage 2, 2A extends to upper vagina, upper 2/3, and stage 2B if it invades the parametrium. Stage 3A if it goes to the lower vagina, which we said lower 1/3, or 3B if it goes to the side walls, okay, or the pelvic wall. Stage 4 we said metastasis. So metastasis either to 4A adjacent structures like the bladder, or 4B to distant organs, for example, the lung. Now, after we know staging, let's talk about treatment. Now here we're going to talk about treatment. Now after you do the biopsy, which we said is very much required for treatment, you're going to check out what are we dealing with. So we have CIN 1, 2, and 3. Now a thing that I forgot to mention is that CIN 1, 2, and 3, once you have that on biopsy, it doesn't mean you have cancer, because they have the potential to regress. Now CIN 1 has 66% of cases will regress, CIN 2 about 35%, CIN 3 rarely regresses. Now, since 66% is a very large number, the treatment of choice is basically observation and careful follow-up. Okay? Now CIN 2 and 3, either you do cryotherapy, which is ablation therapy, or LEEP excision. It says loop, but it's correct. The correct one is LEEP. Okay, so LEEP excision. Now, going into the cancers, if we have stage 1A, which is basically less than 5 millimeters and confined to the cervix, we do cone biopsy. Okay, and if the cone biopsy is not enough and we found cancer cells on the margins, we do simple hysterectomy. Okay, if we have stage 1B, which is basically confined to the cervix, but more than 5 millimeters, or it reaches the upper 2/3 of the vagina, we do radical hysterectomy with pelvic node dissection. Okay, very important. Radical hysterectomy with pelvic node dissection. Now, if it reaches stages 2B, which is basically when the cancer reaches inside the parametrium, till 4A, where it metastasizes to the nearby structures, for example, the bladder, we do pelvic radiotherapy with chemotherapy. However, if it reaches long or far away structures, for example, the lung, we only do chemotherapy. Now, an important question is whether, or if you have a pregnant woman who has cervical cancer, how do you treat? Now, basically, we have to see the magic number, which is 24. Now, if she is less than 24 weeks pregnant, for example, 18, we ignore the fetus and treat the cancer. Okay, now if she's more than 24 weeks, for example 28 weeks pregnant, we wait until she becomes 32 weeks pregnant, we deliver the baby premature, and then we treat the cancer. Now in this slide we're going to talk about prognosis, and as you can see here, in early stages we have very good prognosis. Okay, and it gets worse as you go down. Now another thing I need to emphasize about is after the creation of Pap smear, which is, as we said, is a very important and great creation, the numbers of cervical cancer have dropped drastically. Okay? Now, talking about prevention, we have a vaccine, quadrivalent vaccine, or we call Gardasil. Now, a way to remember this is that this vaccine guards you from cervical cancer, and it's against 6, 11, 16, and 18. Okay, so these are the most common, as we said, most common types of HPV. However, Pap smear is still continued. Why? Because you still have 31 and 33. This can still cause cervical cancer. Okay, now no harm in pregnancy, which is a good thing, and also it's it best works before sexual activity. Okay, now a small summary of the most important points you need to know. Number one, risk factor, HPV. That's the number one risk factor, very important to know. We need to know that cancer usually happens in the T-zone. Okay, the most common cancer is squamous cell. Okay, and screening is through pap smear. However, how do we diagnose? By biopsy, another very important. Symptoms, usually asymptomatic. However, if patients will come with symptoms, usually vaginal bleeding after sexual intercourse, which is post-coital. Okay? These are very important notes to know. Here are the references that I used in this lecture. Now, if you have any comments or questions, please contact us through this email. And thank you very much for watching, and have a nice day.